For our final session of the day, I'm going to invite Dr. McGowan and Dr. Sauer to rejoin us. Are you doing a tag team presentation together? How are we doing this? Excellent. All right, Dr. McGowan's going to come up and talk to us about transition from pediatric to adult care. And then that will be followed by our Q&A panel as the last session of the day.
Great, and thank you again for the invitation to come and speak today. This is a topic that has become near and dear to our group's heart. So I'm really looking forward to chatting with you guys more about areas where we can improve this and kind of hear the patient perspective on if this is important, how we can improve it. So our learning objectives today are to first just review the existing data on EOE transition of care. And then we're going to discuss our experience at UVA in transitioning patients from the pediatric to the adult clinic. And then finally, we're going to talk about some ways that we have identified areas for both research and quality improvement. So part one is just talking about the overview of the transition of care. Sorry, I'm trying to get to a place where I can actually see my slides. Okay, we'll just do it like this. So transition of care is defined as the purposeful, planned movement of adolescents and young adults with chronic physical and medical conditions for child-centered to adult-oriented healthcare systems, with the optimal goal of providing healthcare that's uninterrupted, coordinated, developmentally appropriate, psychologically sound, and comprehensive. So that's the goal. And why is this really important? So as everybody in this room knows, EOE is a chronic condition, and oftentimes the patients are diagnosed in childhood. And currently, we don't have a cure for EOE, just treatments. So ongoing care with medical providers is necessary. In addition, there are healthcare transition programs that are well established in other conditions like inflammatory bowel disease, cystic fibrosis, congenital heart disease, etc. But in EOE, we really don't have great models for transition of care. So there has been some work looking at what the barriers are, and in a couple slides I'm going to go through some of the data that we have, which is, spoiler alert, pretty limited. But some of these have been identified in terms of patient and parent-specific barriers, provider-specific barriers, and then systemic. So I'm going to go through these now. So the patient and parent barriers, the first thing is just normal adolescent behavior. So as we heard in the last talk, the frontal lobe really isn't fully developed until age 25. And so during this time of transition is a time when people are going to be more rebellious. There's also decreased medication adherence during adolescence and developmental challenges as a result of the chronic illness, which we just heard about in our last talk. And then finally, and I've definitely experienced this in our clinical practice, there's a lot of parental and patient comfort with the pediatric provider. So oftentimes this is somebody who they've been following for years and years. And the thought of transitioning from that provider, no offense, Dr. Sauer, to a different provider is sometimes really scary for the patient and for their families. Then in terms of provider barriers, I'm internal medicine trained, and so my entire residency was treating adults. We never had any discussions about transition of care from pediatric to adult care. That's just not part of the training that a lot of our providers have. In addition, there's many instances where there's insufficient communication between providers. So it's great if they're at the same institution, but even then, sometimes it's hard to really communicate the exact plan of management between providers. And then it's even worse in the community when you've got an allergist and a gastroenterologist or two different gastroenterologists. It's really hard to convey, the nuances of a particular case. There's also sometimes pediatric providers have distrust of the adult medical system. There are differences in the way that pediatric providers and internists practice, and sometimes they don't really think that their plan is going to be continued on in the adult realm. And then adult providers have inexperience with adolescent development and means of interacting with adolescents. And finally, there is a lack of knowledge about EOE and EGIDS in particular among various providers. So even among specialty providers, sometimes people don't recognize the nuances of treatment of EOE and EGIDS. And then finally, systemic barriers. So one of the big ones is we really don't have that many examples of successful healthcare transition programs. There's also a lack of funding of the programs. So oftentimes having a transition coordinator is one of the best ways to make sure that this works, but that costs money and it's not something that's really funded by different institutions. There's also adequate reimbursement for transition services. So these are, lengthy appointments to talk about this, and a lot of healthcare systems now are very RVU, or basically the metric that you can get reimbursed for. They're centric on that, and this isn't really a high generating thing for that. There's also potential change in insurance coverage during the transition period if people are getting new jobs, if they're going off their parents' insurances. And then there's disparities in access to EOE care, which Dr. Cleon had talked about today, where maybe you have a pediatric provider in the area, but you don't have an adult provider. So now going over the review of the existing data. So this first study was published in 2017, and it was actually, I think, co-sponsored by APFED. And so in this, they had 67 patients who had either recently transitioned or were undergoing transition, and they basically surveyed them on what were the barriers that they experienced during the transition process. And the things that really stuck out the most were around dietary therapy. And so here you can see in the red are the areas where people felt very uncomfortable. So planning meals, shopping for food, and then basically cooking their food and managing their diets. I will say that this was in 2017, and so I think the treatment landscape has probably shifted with the approvals of dupilumab and with budesonide, where I'm not sure how many of these people in the transition period are undergoing diet now as they were in 2017, but I still think that these are things that are applicable that we need to discuss. And then in addition, the other challenges, the biggest thing was about insurance, how to navigate insurance companies and approval and finding insurance. That was another barrier that is still very relevant today, even with the changes in treatments. So the next publication was in around the same time. This was by Evan Dellen's group down at UNC. And what they did here is they basically just assessed how ready somebody was for transition. And so they used this validated form called the STAR RX, and it looks at different domains of how comfortable and ready somebody is to transition to adult care. And so you can see the different domains here in terms of medication management, provider communication, engagement during appointments, disease knowledge, adult health responsibilities, and resource utilization. So what I want to point out here is that both patients and parents did not feel ready for transition. So this is out of a score of 90, and everybody was basically 30 to 36. So really poor knowledge at this point of transitioning and readiness to transition on. So this was a proposed model that was then proposed by the group, and I'm going to actually skip this one because it's really very fuzzy, but this is a similar one that was published just in 2022. And so essentially with this, starting in late adolescence, the goal is really to just introduce the concept of healthcare transition, that this is something that's going to happen in a couple years, and getting the patients to have a baseline knowledge of their disease and the medications that they're taking. At the same time, the providers need to start thinking about who is going to be on that transition team. So who are going to be the providers who are taking care of the patient when they come into adulthood? Is that an allergist, a gastroenterologist? For patients who are neurodivergent, are they going to have somebody in developmental pediatrics or a psychologist? Really getting the entire team involved so that you know who the handoff is going to be eventually. Then when they hit mid-adolescence from 15 to 18 years old, there's a lot of more education about the medications that they're on, the risks and the benefits of being on those medications, and recognize the need for adherence to some form of treatment as they're going into adulthood. And then at that point also, that's the time when you really want the patient to be participating in the decision making. So making sure that the therapy that they're on is something that they're feeling comfortable with at that time, because that may be different than what they were on when they were 11 years old. You know, when they're 18 and they're going to college, as we talked about earlier. The treatment, the needs for treatment or the desires may be different. From the provider perspective during that time, it's a really important time to educate the patient about, again, their disease course, their medications, the importance of adherence, and then also allowing them to start taking some responsibility for taking their medications or making appointments, et cetera. And then finally, around age 18 is when we do the official transition. And at this point, between 18 and 22 years old is when we want the patient really to be more responsible for making their appointments, taking their medications, showing up for the appointments, et cetera. And from a provider standpoint, during that time period is a time when we want to do an official handoff from the pediatric provider to the adult provider and do kind of a warm handoff where you talk about the patient and then actually a concrete handoff where you are having a joint visit or something where you're actually transitioning the patient. So this is an ideal scenario, right? This is what we all aspire to. And it can be really hard, and in the community, incredibly hard to get all these pieces together. So I'm going to talk now about our experience. So we are kind of, as we mentioned today earlier, like we're an ideal setup for this healthcare transition. Only because we've got the pediatric multidisciplinary EGIC clinic, and so that's me, Tegan, who you heard from earlier today, and then Barrett Barnes, who's a pediatric gastroenterologist that we work with. We've been working together for 8 years. Like, we've got this down. We have this clinic. We have the exact same clinic on the adult side. So this was us a while ago. I was pregnant with my twins, who are now 7. So this was many years ago. We need to update that picture, Bryan. We have the exact same clinic on that side. We have research and nurse coordinators, and we are in an academic setting, so there's less billing pressure. We're all in the same medical system. We can share notes, and we talk all the time. And so we decided that we were going to go ahead and initiate an official transition of care program. But the first step was really to figure out how well we were doing. So again, we're an ideal setup. So we looked back at the rates of successful transition from the pediatric to the adult clinic. And this actually, the dates were wrong. It was 2018 to 2023. And we defined successful transition as completing the follow-up visit with the adult provider or having completed an endoscopy with the adult provider. So during this time period, we identified 34 patients who met those criteria who were eligible for transition. And only 9, 26% actually transitioned. Again, this is an ideal setup, and we still only had 27% of our patients actually made it to the adult clinic. So on one hand, like, this is somewhat good news because anything we do is going to be better than this, right? We have nowhere to go but up. But at the same time, this is really bad, you know, and this, again, kind of, it's better, I think, than other community places would be, but still not great. So here is what we implemented. So this started in November of 2023. It's very similar to what we kind of had seen on other slides. And what we have is at the first visit between 13 and 15 years of age, we introduce the fact that we now have this transition program. And we, again, talk about the fact that in 5 years, they're going to be going to a different provider. Then from ages 15 to 18, we have them complete those STAR RX forms that were in the UNC publication. So this is really assessing what the readiness is of the individual patient. And during that time, we're identifying the areas that they may need more education on. And so Rebecca Ravel, who is our wonderful research coordinator, has designed all these patient education materials that are currently being vetted by the patients. And if anybody wants to help us with that and give input, that would be amazing. But basically education materials on the disease state, the medications, the provider team, but then also things like getting insurance and calling insurance companies, getting prescriptions, what the prescription bottle looks like, things that we can use to educate our patients along the way. And then during, when they get to the transition period from around 18 years old, we're doing a soft handoff between the pediatric and the adult provider. And then we finally have scheduled our first 2 clinics for a joint clinic between Dr. Barnes and Dr. Sauer and myself, where we are doing an official handoff where we're all together in the room at the same time. So to date, we've developed the formal transition program. It started in November 2023. We integrated those forms that I mentioned into Epic, and so the patient gets them before their visit, they fill them out, and then we can look at them in real time. The education materials have been developed and are being vetted, so again, we would love your help on that. And then we've scheduled the first 2 transition clinics for August of this year, so just next month, and then in January. We're trying to space them for when patients are back from college or getting ready to go to college. So finally, some future opportunities, and I think these are areas where hopefully we can work to break down some of these barriers. So again, nowhere to go but up. Our data was not so fantastic, so I think anything that we do is going to be better. All right, so in terms of the patient and parent barriers, I think as I've mentioned a couple times today, I think that shared decision-making at the time when the patients are getting into that transition period is really important to make sure that what we're doing for treatment is what they feel comfortable with. We also want to identify those key stakeholders who are going to be in the future team, and then providing education to both the parent and the patient about transition and about the disease so that they're ready to go when they turn 18. In terms of for the provider barriers, I think, oops, not going. Okay. I think we need to have more education about healthcare transition, and if we can have some common templates that people use, so therefore, even if somebody's not in the same institution, but if they're going between providers who are knowledgeable about EOE, if there's certain metrics that they can kind of look at on the template, that could be really helpful to get a snapshot, of exactly what the patient's been treated with, where they currently are in terms of remission or active disease, et cetera. And then I think creating a local network to facilitate transition would be really helpful too. And this is something, at least in the state of Virginia, that we're currently working on. So we have a meeting coming up in November of this year where we're trying to bring in community gastroenterologists and allergists throughout the state to essentially create kind of local nodes of networks and pediatric and adult gastroenterologists so that people don't always have to come to a tertiary medical center, but could be really treated in the community closer to home, and making sure that the people wherever they're living in the state are getting, top level care and evidence-based care. And then finally, in terms of the systemic barriers, once education materials are developed, if those could be disseminated to other institutions, that would be incredibly helpful to have those resources available to give to patients. We also need to really test these transition models to see what are the components that are actually effective and what are the things that are essential versus having these, massive spanning things that take a lot of resources. Can we narrow that down to like 2 or 3 things that are really important to make sure that we successfully transition? We also want to provide patient education for navigating insurance, and then ultimately, if we can make some policy changes to improve the reimbursement for these visits, that would be ideal. It would be amazing. So in summary, there's currently limited data on transition of care from pediatric to adult providers in EOE. And there's current barriers to successful healthcare transition, including patient and provider barriers and systemic factors. And then quality improvement and research into optimizing healthcare transition to EOE is ongoing and is very important. So I think that's it. And I'd like to thank you guys for having us here, and hopefully we can have more discussion about this. And I'd really like to thank our patients who have, inspired us along the whole way to do this.
All right, I would like to invite our panel up here, and Dr. Sauer, you're going to join us. Tracy, there you are, Tracy and Declan. Just making sure you were there too. So the audience has met 3 of you, so in the interest of not repeating ourselves, Declan and Tracy, could you tell us a little bit about yourselves, and then we're going to ask some questions, allow the audience to ask a few questions as well.
Great. Hello, my name is Declan Cassidy. I am from Michigan, and I've been living with EOE for about 5 years now. I was diagnosed when I was 12 years old, and we are currently looking at to make a good transition from pediatric to adult health care.
Tracy Cassidy, Declan's mom, and I have been a mother living with a child with EOE for 5 years, so have done a ton of research, and like Declan said, we're already starting to make the transition.
All right, and I think you've met everybody else up here on the panel. While we're waiting for online and audience questions, Declan, could you share a little bit, and Tracy, the same question will go to you as well, what you've done so far to prepare for being independent in your health care?
Well, it's a little difficult at the moment because obviously there are so many different barriers that was just talked about, and I think right now the main thing that I'm trying to do is be more independent when it comes to going to my doctor's appointments. So taking the lead on asking questions, having a good communication system with the doctor instead of my mom having to constantly answer and ask questions. So I'm trying to be more involved in my own health a little more, and I think that's one of the main things that we're working on right now. And again, things that have to do with prescriptions and my medication, we're also going to work on to trying to make sure that I have a concrete understanding of everything that's happening. So I think that's really important.
Yeah, it's, just trying to make the transition. I think we're gonna, work throughout the next year, but like Declan said, I think, the biggest thing we're trying to accomplish is definitely have him be independent and his own advocate, where I've always been the one speaking at the appointments, asking the questions. So if we can better prepare before practice, write out some questions, what are the issues you've been having since your last appointment, and just let Declan take the reins, and I take a back seat, which is hard for me since I've been his caregiver and advocate for the last 5 years, myself and his dad. So it'll be tough, but we'll do it.
Yeah, I totally get that, having been through that with Ryan, and our car ride to the doctor's appointment would be what's your ask, right? And make sure you get it out there before your 30-second appointment is up. All right. Audience question.
From online, we've got a question. There have been several comments today about finned and non-finned fish. So people are curious, are the only non-finned fish shellfish? And do you see patients that can eat some finned fish and not others? Or even, and it goes on to list mollusks, scallops, octopus, squid, lobster, crab, and so curious, tell us a little bit more about finned versus non-finned fish.
Provide some detail on the fish comment, will you?
Yeah, you open the door. So there is within the seafood family, it's either shellfish or finned fish are kind of the big first branches off. So shellfish being further subdivided into shellfish like crab, shrimp, lobster, and crawfish or crayfish, depending on where you are. And then the other part of that being mollusks. So those are all kind of within the shellfish family, but somewhat different proteins. So there are patients who can tolerate, again, a lot of this data is from the IgE-mediated food allergy side of things, but there are patients who can tolerate, say, mollusks, like oysters and scallops and mussels, but cannot tolerate the shrimp and crab and lobster, so the shellfish piece of things. Fin fish is the other side, so all other fish that are not shellfish. I think the data is very inconclusive in terms of if you can tolerate kind of one or if it's all, there's a lot of proteins that are cross-reactive between the entire family. And so most times, if you're allergic to those proteins, it's the whole family that's out. There are some exceptions where people will be allergic to, say, just tilapia or something because there's minor allergens that they're allergic to. But that's more rare than the general circumstance of just being allergic to all. But just because you're allergic to seafood doesn't mean it's both finfish and shellfish. That makes sense.
All right, thank you for that.
That was a wonderful answer, and that just reaffirms why I do clinic with Emily, so I don't have to answer that question.
Ryan, you had a little bit of education on the transition transfer of care process, just a little. What would you say, what are some of the barriers you've encountered as you are now firmly in the adult healthcare system? What have you figured out?
Yeah. When you were giving your talk and you guys were saying you're the perfect setup for this transition process to happen, I was like, absolutely. Like when I was a pediatric, I was out at Denver. They have these great multi-care teams where I was seeing an allergist, I was seeing an asthma doctor, I was seeing GI. Like it was very an inclusive experience. And then I had to switch to the adult side, and now I have a GI. And if his one day of clinic doesn't get canceled, sometimes I get to see him each year, and then I have my allergist, and as long as she's not out on maternity leave or moving to industry, like I get to see my allergist, but I've been through 4 in the last 3 years.
4 allergists in 3 years.
Yeah, 4 allergists in 3 years, and then I have an endocrine doctor who, again, is, I see about once a year, and then they don't talk to each other whatsoever, so I'm the go-between there. So it is very difficult, and as you alluded to, I had the full backing of APFED to provide all this knowledge and insight on how this transition should go. So you guys were the ideal clinic. I think I was more or less the ideal patient to manage this transition, and it is very, very, very difficult to do when you're not in that kind of multi-focused care team. So I'm glad that exists at Virginia, but when you're not at Virginia, you really do have to take the time to make sure you know if you're going to see your doctor, when you're going to see your doctor, what questions you have, both from yourself, but also from your other providers to, if I'm going to my endocrine doctor, I'm going to say, hey, my GI prescribed this new medicine. Is this going to interfere with anything else I'm taking? Do I need to think about different blood tests or whatever to supplement and support that? So there's a lot of challenges to face, and unfortunately as the patient, you're kind of left in charge of all of that communication if your doctors will not be communicating with each other.
You become your own care coordinator, that's right. Do our doctors have any comments? Do you prepare your patients for getting on the phone with an insurance company to appeal a prior authorization as an example, or a prescription denial? What goes into that education at the patient level?
Yeah, so I think the least, I think the insurance company has been identified both in that little study as well as in our patients as one of the biggest things. I think it's really daunting thinking about getting the prior authorizations and going through that. So our education materials at this point are, starting out as basic as this is what insurance is. This is, here's where you find your number, and this is where you contact things. And so we haven't yet put the patients in charge of doing appeals, but it's more like this is how you're this is just the basic information of what insurance is and how you're going to navigate it. But again, I think patient feedback in terms of what would be really helpful would be amazing, because we just kind of base this off of what we think is helpful, but that's not always what's most helpful for patients.
Do we have an online question, Jen?
We do. We have additional questions coming in online. Alrighty, so you've talked a lot about different medications today, and so we've got a question coming in about how to go about making changes in medication and diet. Do you do multiple at a time? Do you one at a time? So for example, this person is on multiple medications and avoiding multiple foods, and they want to know, how would they go about making a change?
Yeah. I can give you my general thoughts on that. So if somebody is on both diet and medications, and there was never an assessment of they needed both of those, because sometimes that is necessary to have remission, we will oftentimes try to pare down to just one of those things. So meaning only diet or only medications, and see if that is enough to control the disease. That does require a repeat endoscopy at some point, usually 2 to 3 months down the road. If it's a matter of they're on many different foods they're avoiding and in remission, that's a more tailored discussion of kind of, are we doing one food at a time? Are we doing the whole food groups? Are we doing lots of food to get to just a 2 food or a 1 food, depending on the history of the patient and what they've tried before? But in general, we try to not do too much at the same time if we can avoid it, because then you don't know what is working and what is not.
Yeah, and I'll say from the endoscopy standpoint, the endoscopy we do is going to test the response to whatever a specific person is doing for their EOE. So if they're doing diet and steroids, at the same time, we don't know if steroids would have worked by themselves or diet would have worked by themselves. So it's not as helpful, because each of those treatment options, in general, the vast majority of the time, you're not doing 2 of those. Now, there are complicated situations in which folks are doing 2 of those different options at once, but I would say those are more refractory cases rather than the standard case. And so whatever somebody is doing at the time of the assessment of symptoms and endoscopy, that's what you're testing with that endoscopy, biopsy, and the symptom assessment at that time. So I think trying to sort out which way you want to go on those is the right thing to do, and then discussing with the provider team to figure out how to implement what you want moving forward is the best.
All right. Tracy, Declan, what kind of things are you thinking about and doing in preparation for college?
Well, one of the things that I kind of talked a little bit about earlier is making me more prepared, to handle my prescriptions and medications. So one thing that I think we're going to do soon is that we're going to create my own CVS mobile account, so I can actually not only look at my prescriptions and organize it and manage that, but also get used to the format of communicating with my doctors as well that have to do with the medication. So if I have to do anything with them, if I have to add any, as well as knowing when there's a refill or anything like that just related to my prescriptions. And I think that's going to be really important for me to learn before I go off to college, so I can be prepared and feel comfortable with that.
And actually, 2 weeks ago, Declan's pediatric GI retired, so we got a letter that, we've got 4 weeks to schedule an appointment before he goes. So, it actually will be a good time to transition, because we won't transition to another one in the practice, in the pediatric. But it will be interesting, because we want to see how it goes and, who they're going to recommend, how it'll be really a true test. But for that appointment, Declan and I have been working on more about practicing. I think it's really all about practice, right? So role play, pretend I'm not in the room. What would you ask? Again, what are your symptoms? What do you need to get out of the appointment? And then thinking about, he does have a good group of doctors that work together, because where we live, they all are in a pediatric specialty area, with the exception of his dermatologist. But it's going to be, practicing on, like Ryan said, if they're all not talking, and I know that they won't be, is what's happening as dermatologist happening because he has EOE, Raynaud's was one thing that came up. Is it connected? And so we just have a tough time, because the dermatologists and some of the doctors are outside of those specialties. So I think we've been getting practice and didn't know we were getting practice, but probably for what the future holds. But just kind of being the leader and an advocate for himself when he goes away.
All right, thank you. Jen, you've got a couple of questions online?
We do. Alrighty, the next question that come in is about PPIs. People are curious if a PPI can be used as needed if experimenting with triggers, or if a PPI needs to be used daily or lifelong to be effective.
Want me to handle this one? I'm not sure I totally understand the question exactly. So proton pump inhibitors can be a treatment for EOE, as we showed you. They don't really work on an as-needed basis, honestly. Just their mechanism of action for, in general speaking. So they're really meant for really daily medications. In general, if we're treating EOE with that, they're going to be on daily medications for that. If you're going to go to a food elimination diet and talking about some of those triggers, experimenting with some of those triggers, again, we do it very systematically because we want to know what those triggers are, not just, I just caution experimenting with triggers is a little bit not as systematic as I would suggest, because you're not going to know unless you're fully committed to eliminating that and then getting an endoscopy when you reintroduce it if you are in remission on what you're eliminating. So there are some people that need to be on a proton pump inhibitor and while they're, in order to get into remission on a food elimination diet, and that's because all of our esophagus has some acid exposure time. And when we have acid exposure in our esophagus, there are some kind of histological changes that happen that probably make it more easy for your body to see the triggers, if that makes sense. The tight junctions of those cells loosen up with acid. Your body can probably see those triggers easier and maybe have a more robust response. So I think in general, I don't use proton pump inhibitors on an as-needed basis, because that's really not mechanistically how they're effective. And for EOE, they just really don't work well in that setting. Do you want to add anything?
Rebound symptoms.
Rebound symptoms, like
if you're not taking it every day.
Yeah, so the reason they don't really work is unless you're taking it every day is it'll kind of control some of the acid pumps, but then you'll have a rebound kind of hyper acid, next day or the day after when you stop it, and so it kind of gives you like big waves in the amount of acid in your stomach, and your esophagus is going to see some of that. Anybody that knows boats, like the big waves are the ones that are really bad. Little waves you can kind of tolerate a little bit. So. And that's also why if somebody is on a proton pump inhibitor, when they stop it, they're also going to have a week or so of pretty significant hyperacid secretion rebound period of time. And so just words of caution on that. So I think that would be my response to kind of that question. I think I answered it, but if somebody wants to type in a clarifying point, I can readdress.
You have another one?
All right. Ryan, this question's for you. What do you see an endocrinologist for? This person has thought of seeing one, and they're curious what kind of role it plays in treating your eosinophilic disorders.
Yeah. I'm sure I could give like my case study highlight like you guys were doing earlier, and you could guess where we went wrong and ended up an endocrinologist. I was on some high-dose systemic steroids for years before there were really EOE treatments out on the market. So I tried the budesonide slurry. I was doing inhaled steroids. Those were not very effective. I did diet therapy as well, which, again, for me, were not very effective. So I ended up on these high-dose systemic steroids. And a side effect of that, I'm sure many of you know you should not take high-dose systemic steroids for a very long time. I did on and off for 18 years. And as a side effect, I had bone loss. So we had that discussion before with the dietitian about bone density in EOE patients. So I do have osteoporosis, and the endocrinologist essentially is managing that. So it's not directly from my EOE, but more as a side effect of my treatment options when I was younger.
And it was low dose, but yeah. Mm-hmm.
Well, okay.
Same damage.
Long time scale, too many doses, yeah.
All right, next question. Has there been, for transition of care data and research here, have there been any discussions about leveraging data such as interfaces with EMRS to collect data from across the U.S. and or using state HIEs to compile Medicaid data related to eosinophilic diseases and transitions of care?
Can I rephrase? Is that okay?
Yes.
Okay. Yes, so the question relates to using existing means for which we collect patient data. There are many of the electronic health record systems are now linked and using that for purposes of studying, as is done by public health agencies for some other diseases.
Yeah, that's a great question. To my knowledge, when I did the literature review just a couple of weeks ago, in preparation for this, there was nothing that has looked systematically at it across the United States. I think it's a great idea, and there could be things like TriNetX is a interface that you could use to look at that longitudinally in patients. Oftentimes, some of the other data comes in yearly increments, and so it would be a little bit challenging to do the longitudinal aspect on that. Like Medicaid typically is a year that you would get it, but there could be ways that could be looked at. So no, I think it's a great question. It doesn't exist yet.
Any other questions online? Oh, or do we have a question here?
Okay, yes. Alrighty, are any of the patients on the panel currently taking a biologic? If so, can you share your experience with this versus PPI swallowed steroids?
Declan, would you mind just sharing some of your treatment options that you've tried over the years?
Yeah, I mean, I don't think that specific one that was mentioned is what I'm doing, but I am taking PPI for, and I'm taking it on a general basis, everyday basis. And I believe that's the only major medication that I use daily, because I have stopped my trigger for EOE is dairy. So luckily, when we were doing testing to see what I was reacting to, we just tried dairy, and we didn't try to do a full elimination diet. So our doctors just let us take out dairy, and then that turned out to be the one that was really causing everything, because the next scope that I had, my eosinophils were at 0, which was really good. It was great news for us. So now we're just sticking with the proton pump inhibitors just to kind of regulate everything to make sure that everything is just stabilized and it's okay.
Yeah, I think PPIs, as we heard from the other talk, was pretty effective, and that was something that I had tried as well, and unfortunately for me that did not work. So I do take a biologic now, which I've found to be more effective for my specific case, but again, as you guys discussed, biologics are hard to get on. You usually do have to go through the PPI first to get insurance approval. So I found for me that's been very effective. I will say I also have eosinophilic asthma, so the biologic that I am taking is indicated for eosinophilic asthma instead of eosinophilic esophagitis. I'm taking benralizumab instead of dupilumab, which is indicated and approved for EOE. But that has seemed, for my case at least, to help greatly with my eosinophilic asthma and also help with my EOE along with dietary therapy as well.
Next question, is there a database of food protein structures? If so, what is it called and how can they access it?
Do either of you have an answer to that question? Crude protein database.
I don't.
Beyond the scope of this panel. Beyond the scope of this panel. Other questions? No? Okay. Tracy, one of the things I've found helpful, and you may encounter this as Declan ages into the adult healthcare system, is when there's an issue with, be it insurance, pharmacy, healthcare provider, once he's 18, you are no longer permitted to assist, right? So what we found helpful is three-way calls, and the philosophy that you don't take no from someone who's not allowed to say yes. And that has enabled us to work through some of the processes that are difficult for an 18-year-old to understand, right? That you have to understand your health insurance policy, how many appeals do you get an external appeal, what's in network, what's out of network, right? What's co-insurance, what's a copay? It's very, very complicated, and I think it can be very challenging. My daughter's almost 27. We still have to help her with some of these, navigating the system on those three-way calls. Is that anything that you've thought through? And
No, but that's a great idea, because that was my fear, is as much as we can try and practice, he'll still be 18. It's a year away, or probably less than a year away. Mm-hmm. So I worry about that, right? If he does need support or assistance, what we're going to do. But that is a fantastic idea. So thank you.
all right. Any other questions? I've got a couple of questions, Declan and Ryan, and dining hall, right? Or high school cafeteria. How does that work? Does it work if you're on a dietary restriction?
Well, usually when I go to school, I have a packed lunch that I bring, so that way I know for sure, obviously, everything's going to be safe. But there are some days where, of course, I have to eat at my school cafeteria. And the really, annoying part about how, the food was set up there is that there's not really, any clear labels that really say, oh, this has this type of ingredient in it, and I think my mom had to scroll through how many pages of
30 to 50.
Yeah, just to figure out what was in all the foods that my school has, and that's just a complete hassle to do. And it would just be much better if there were some labeling anywhere, and there's hardly that. So that's why whenever I did get lunch, I liked the same thing over and over again that I already knew that I could have, because it was the easiest option.
Or you don't eat.
Or yeah.
Not great.
Yeah, it can be challenging. How did that go when you went to college?
Oh boy, yeah. Trace and I were talking about this earlier, because you mentioned you had this huge binder to look through of all the ingredients in the school lunches in high school, and I was like, that's nice that they provided that. When I went off to college, I met with the head of the dining halls at my school. And I sat down and I was like, I'm allergic to this and this and this and this, and I need to make sure I get enough protein, but I can't eat any meat. There's a whole long list. And he was like, well, if you want to eat in the dining hall, I think that one booth has a salad bar, so I would avoid the dressings. And that was all of his advice for the dining hall. And we had a required $2,500 dining plan freshman year. And I was like, all right, I'm not going to pay $2,500 to be able to have some lettuce and maybe mushy tomatoes. So that was not very effective. They were not very willing to work with me, and luckily as an accommodation I was able to get an apartment-style dorm in the upperclassmen housing, so I was able to have access to a more personal kitchenette. All of the freshman dorms had a shared kitchen for the entire hall, and I was like, well, I'm not going to use one shared fridge and all of these shared dishes with 40 other freshmen. I think that's probably a bad idea for many reasons, so I was able to luckily get access to a kitchen that I could use when I was at college. But I was not able to, eat in the dining hall, which is kind of a big social aspect. I'm glad you've been able to find some things at the school cafeteria where you can still eat, because as we've talked about, there's a social aspect to EOE that is not something that goes away as you get older, but the amount of accommodations I think that people are willing to give you do kind of go away as you get older, unfortunately.
Yeah. Speaking of which, as part of the transition education you do you talk to these teenagers and their parents about disability law and how to request accommodations in college or in the workplace? Does that come up in the education materials?
Yeah, that's a great question. At this point, it is actually not, but I do think it should be included. We do have a lot of patients who are going to college, and for them, they themselves oftentimes will get the accommodation stuff when we fill them out and we work with them on that. But I think having a little bit of education about that, about knowing that exists and that they can do that for their colleges would be really great. Mm-hmm. So yeah, it's a good addition.
At the end of the day, they've got to advocate for themselves in a world that may not advocate for them. Yeah. Jen's left. Declan, Tracy, anything you've heard today that will change how you approach the transfer of care?
Well, I think that seeing or hearing everything today as well really opened my eyes to learn that this is actually a a really big issue, like how difficult it is to transition. I thought I knew for me it was going to be difficult, but apparently that it's such a big problem, and I think that it's really important what you guys are doing. That is amazing to help guide people and help teens as well as their parents transition to a higher level of the adult healthcare. And I think that hopefully over the next couple months we can really start making a larger impact on getting ready for it and training as much so we can have a system going where I am more comfortable with what I'm getting into. So I think just maybe even making sure that everything with my doctors are connected in that way is also really important. So.
Yeah, and I think that to that point, you offering assistance, because I just research as a mom whatever I can to figure out what's going to work for us, but there are things that I don't know about, the insurance and how long we can do that, and can I speak for him? So this has been really helpful for me to even enhance the plan we already had in place for the next year.
All right. Any more?
I will say experientially, I think, folks, you're gonna crush it when you're in a great spot. You're gonna just thinking about this is half the people your age haven't even thought about it, anything. And there's when you look back, there's a transition. Those of folks, my kids are teenagers, but as you start launching your children into adulthood and they start adulting. There's transitions in so many different parts of life, and this is just one additional part of that, I think. And I think for experientially, folks transition at different paces as well. So I don't, there's some folks that aren't ready to transition at 18, and the pediatric, folks may see them until they're 22, and then start some of this transition, and so. I think there's just being aware of that and understanding that folks are going to transition to those different spots at different ages. And sometimes it's easier to just get through college with the same. You're not going to have this opportunity. I'm sorry, because your pediatric gastroenterologist is not going to be there. But sometimes folks go through college and then transition as they kind of go on to do either graduate school or jobs or other things in their lives, and that's kind of also another transition point as well that we've experienced. And we get the opposite too. We have some people that are coming to college and they're transitioning to us because now they're at the University of Virginia where we practice, and they're like, hey, we're going to do this transition now. And so.
Well, his pediatrician actually offered to keep him on during college, and Declan is very comfortable with that. Yeah. She was really the one that helped us get an appointment with a GI doctor and help diagnose him. So that, we still have the connection, but that's great, and he's happy about that.
Excellent. Any other online questions or in person? Oh, sorry. Yeah, missed you.
Is it always necessary to transfer to an adult specialist? I have a friend that's in his 30s. He has CP, and he still sees the specialist that he saw as a child. So is that like a specialist decision as to whether you see an adult provider or stay with them?
Do you want me to answer that? I actually do some of this for a living.
Oh, do you? Okay. Yeah, go for it.
I think it's dependent on the healthcare system. So some pediatric healthcare systems have written into their mission that they will only treat children, and in those cases, it's required. Some pediatric healthcare systems will take care of these medically complex adults in the pediatric healthcare system and don't have that requirement. So it's very much dependent on the healthcare system that they're seen in. But there are many that will keep those adults in pediatrics.
That would be a question for the provider. How long would you continue seeing this individual? Okay, thank you. All
right. Any other questions online? No? Okay. I want to thank our panelists. This very brave to sit up here, not the doctors. We're thanking you for being here, but you don't get courage points. So I want to thank you guys for being up here today and sharing your stories and sharing your expertise with us. Join me in giving them a round of applause. All right, I'm going to invite Mary Jo Strobel, APFED's Executive Director, up. She has a few awards, I believe, she's going to give out, and she'll give a few closing remarks, so you can all be free to go forth.
Thank you so much. Before we wrapped, I want to recognize two community members who go above and beyond year after year. When I first came on board with APFED some dozen years ago, these two, they may not realize this, but they really taught me a lot. They taught me a lot. And they've been here way before my time. In fact, there you go. This was way before I knew them. Zachary Brunet, Ryan Piansky, they were both community members when APFED was founded. Zach attends our annual conference year after year, and he helps with our teens and our mentorship programs. In addition to community building, he also contributes to research initiatives, to awareness campaigns, and he freely shares his experience with research teams and pharmaceutical developers that are looking to gain a deeper understanding. Ryan, I met first on Capitol Hill when he was in middle school. And today he has a beard, and this is very, I just can't. But, you know, I remember meeting him and watching him spend a very long day going door to door, visiting members of Congress to share his story and talk about why research for eosinophilic disorders was so important. And since then, he has gone on to make significant contributions to education and awareness and community building. Today, he is the host of APFED's podcast series. He helps with moderating duties at the conference, and he's just a trusted source of honest feedback, as is Zach. So I would like to invite them both to the stage. I have a small token of our appreciation for you. And because I cannot thank them enough, I have invited APFED's founder, Beth Mays, who's now Beth Camacho, to join us online to say a few words as this award is named for her.
Hello, hopefully you all can hear me. It is an honor to be here, and I apologize for technology issues here, but technology being my dogs. And since I'm at my home office here in California, but I do apologize that I'm not there in person, especially for the two of you. While I've stepped back from the day-to-day activities of APFED, I do keep up via Wendy and Mary Jo, among other people, including Ryan and Zach even. I have not left the space entirely, but I work in industry, and to maintain transparency, I do work in sales and marketing and patient advocacy for EVO Endo. I like to maintain that transparency, but I am the founder of APFED along with two other moms, and I'm just honored to be here today, especially honoring these two young men. That this award presentation follows a discussion about transition of care, it could not be more fitting. I myself am extremely passionate about transition of care. It's something that I talk about almost every day that I'm with physicians out there in the field. But this award is going to two young men who have grown up within APFED's family, and they exemplify the successful transition from pediatric and parent care to the hybrid of the parent and the patient care and participating in their own health. and then onto their own independent lives. Literally every step of the way, I've watched them both grow into their lives with eosinophilic disorders, but not being defined by them. They're both smart, capable, and truly kind young men. They're a credit to their parents, the support that they've received in their endeavors to include them in the programs and into their own self-care. I met Zach. He was probably 03, 04, I think. He was about 18 months to 2 years old. And I went to a family support group meeting up in the Northeast, and he sat in my lap. He probably wouldn't want to do that anymore. But I cuddled with him all afternoon while I was in that meeting, getting to know his mom, among other parents. And I could have held him forever on that day. He was just so sweet. And I now have a lifelong friendship with both him and his family. I also met Ryan via his parents, who has both started working with APFED in about 04, 05. She obviously, you both know Mary Jo, Wendy and Mike, as well as Lisa and Dave Renee. They're all of the parents of the four between them. I'm sorry, I'm a little emotional about this because I didn't think I was going to cry, but I'm starting to. But both Brian's parents are very active, as you all know, with APFED. Both of these young men were assisting with registrations, gift stores, especially Ryan in those early days. He was this little young man selling T-shirts to people, just the cutest little spokesmodel ever. And he was very quietly just going about as this little person directing people. And the two of them have been attending meetings and mentoring and supporting. And probably those of you who have been to APFED meetings in the years gone by have probably run into the two of them helping you find your way or providing comfort, etc. And as Mary Jo mentioned, Bryan now hosts the podcast, which he actually interviewed me with co-interviewing Dr. Gleich, which that was as full circle as it could come for me. So, the both of you, as young as 5, 6, 10, into your teen years, you have mentored, you've been friendly, you've comforted people, you have given welcoming chats and just welcomed new people that are embarking on their journey and exemplifying just maturely and fearlessly beyond your years, showing us all the way as patients yourselves growing up with this disease. And it's a new disease, and you're in that first generation. You're among the first generation to live with this disease, and we watched you all grow up as parents, and you showed us the way. We didn't show you the way. And I take that to heart as a parent myself. You both are campaigned on Capitol Hill. You've sat on numerous panels and advisory boards, lending your expertise as a patient yourself. You've been the faces of countless campaigns, calendar children. I have some of my APFED archives here. The humble beginnings of our brochures and our materials, the conferences, the walks. APFED has grown way beyond these, but I have all of our materials from the very beginning that you guys helped create, distribute, and participate in. And also worked with even other adults when you were kids, comforting them with their own children. Your images are scattered among the history and the footprint of this organization. Truly, your contributions in this space and in this organization cannot be calculated. I cannot begin to describe how grateful I am. You both now lead by example, where so many young people who may not feel they can contribute until they're older know that they can because of the two of you, and several others out there, but you two really lead the way. You show everyone, not just them. My note says them as the pediatric children, but you actually show all of us that the pediatric patient voice is heard, it's represented, that they don't have to wait till they're older to be heard and represented, and you exemplify that. You can live a full and vibrant life and go on to very exciting college careers and careers that follow after that in your adult life. And it's done through education and self-advocacy. And you just shine in every way in all things that you've done. It probably hasn't always been easy, but you make it look easy. So Ryan and Zach, you give my heart a lot of comfort. I know that when we built this organization, we had a vision for the future. We didn't necessarily think of the legacy of APFED and this community when we started it. We just hoped that it would go on. And I take so much comfort that the intended mission of this organization and the future of eosinophilic disorders really as a whole and patient advocacy goes on in your already very capable and tenured hands at such a young age. And I just really want to congratulate you both on this award, express my gratitude to you both for your contributions. And I can't wait to see what you do with your lives going forward. And I'm just so immensely grateful to know you both. So thank you for the time and the ability to be there. I wish I could give you a hug. Nobody has to sit in my lap anymore, but I sure do wish I could give you a hug. And I love you both dearly. I love your families, and I love the APFED family and the eosinophilic community. It is truly my heart's passion and my life's mission. So thank you both, and congratulations. Thank you for letting me be here.
How do you follow that, right? I can't. So instead, I'll just express my sincere gratitude for all of you who have joined us today here in DC, the many of you that are online. Your active participation and engagement really underscores the meaning of community. So we've covered a lot of ground the past 2 days, from research to practical strategies, and insights that have just been invaluable. So I would like to extend a special thank you to our speakers and panelists who have generously shared their expertise and perspectives, to our conference organizing team and key volunteers. Thank you for your hard work and dedication in putting this event together. Your efforts and many hours of work and creative thinking were key to bringing us together in person and online to learn, share, and connect. And as we conclude, I encourage our community to continue conversations, to continue collaborations, and continue to drive progress. So we will be back online tomorrow morning for our all-virtual event, which kicks off at 8 a.m. Eastern. We'll cover topics such as EGPA, hypereosinophilic syndrome, eosinophilic fasciitis, and more. So for those of you who are on site, please join us 5:30 to 7:30 this evening for our networking reception. I understand there is a Family Feud style game that is organized by our great volunteers. And tomorrow morning, you're welcome to gather in the Wisconsin room for a watch party for Saturday's virtual event. And thank you to our education partners for bringing us together. Thank you for being here, and safe travels home.